All right, so back to Journal Club after the summer off and plus an extra month. So here we are, October. I'm going to share my screen. I just compiled, I had a couple of resources that we thought this was a good topic. And so obviously I'm going to just do my little disclaimer of I am not the expert on this. So I'm hoping we can have some good conversation. But so this is a great topic and I wanted to share just conversation amongst all of us as far as what maybe is going on, and then share some of the stuff that I got from the resources. So I'll just go, I'm going to switch, sorry. Go down here to the resources of just something from American Journal of Occupational Therapy. So they have a guideline for documentation in OT. And then we use in our program, in the ISU OTA program, we use the a book from Slack, the OTA's Guide to Documentation. It has a lot of really good resources in it, just about all sorts of topics, best practices, using professional terminology. I tried to pull out the stuff that would maybe be the most applicable to practitioners. And then just maybe, some of the nuances that could potentially arise in practice. And that's where I was hoping to get from some clinicians as far as if we can have that conversation of, what codes are getting rejected or denied, or, what are trends that we're seeing. I know with PDPM and skilled nursing, there's all sorts of different changes and challenges, I think, with Part A versus Part B and groups and whatnot. So hopefully we can get a little bit of discussion on that. So this is super fluid, even though I have a PowerPoint, super fluid. So please interrupt and interject if something comes up, or if there's a topic that you want to take a tangent, by all means, please do that. Okay, so a lot of us, obviously we're going to know this, but purpose of documentation, I thought it was just good to kind of clear, delineate some of this, but obviously we're communicating information about our clients, following the occupational profile. We're articulating the rationale for our provision of OT services, and then obviously that relationship of the services to the outcomes. And then documentation can show that clear chronological record of client status, nature of our services, their response to interventions, and then client outcomes. Then obviously a accurate justification, hopefully, for skilled OT services, the necessity, and then justification for reimbursement. So then just fundamentals in documentation. So obviously just following legislation as far as documentation practices, storage and disposal, regulations from state and federal guidelines, while also paying attention to payer and facility requirements, practice guidelines, confidentiality requirements, fundamentals of documentation. Obviously we need to keep, I thought this was just good review. It's like, oh yeah, like having all of this data on every page of the documentation. I'm sure there's plenty of nuances out there of, I remember when I was working at St. Luke's, just hearing about like one spot on the documentation wasn't filled out correctly, and that whole file was denied, and that's pretty unfortunate. Identification of type of documentation, date of services, acceptable terminology, acronyms and abbreviations. There was a whole section in that, the OTA documentation book on terminology and acronyms and whatnot. This is obviously defined in our settings as well. Documentation should include clear rationale for purpose, value, and necessity of skilled OT services. So it highlighted here that the diagnosis or prognosis associated with that is not the sole rationale for the OT services. So we have to put our assessment and obviously probably tie that to functional outcomes and goals, which is what, that's our bread and butter. We need a professional signature and our credentials, and then obviously co-signatures and credentialing when that's required. And then signature of the recorder, which I thought they were probably relating to, like if a student did the documentation, and then co-signature from the supervisor. And then errors are noted and initialed or signed. So here we can do this. So there's a section in this book that talks about, maybe we can come back to this, or I don't know if we want to have a powwow. Where did I go with that? On just, oh no, this is from the AOTA guideline. Hold on. Sorry, I might just do this so I can use my other screen. Okay, so the AJOT article went into content of documentation. Oh, and I'll just, how about I pull it up? Then maybe that would make it where we can look at it together and I don't have to read to you guys. Okay, so content.
Brittany, I can't tell if it's my end or yours, but you're breaking up and
shoot.
I think freezing now. Yeah, I think it's on your end, unfortunately.
Let me get off my internet. Any better? I have internet people coming out tomorrow.
Oh, yeah. No, now it's better. And that might be part of the problem. Like, I don't know if you're like sharing versus just over the sound or not. You might have to turn your camera off, depending.
Oh, I see. Well, let me know. Hopefully this is better. I turned off my internet on my phone and cleared some things, so that should be better. Okay, content of documentation. So I don't know, we could just kind of screen this, but I thought maybe more so into our, obviously our evaluations, where I liked how this reference gave us additional information. Maybe that could help us, you know, like, so summary and analysis. So it's giving us some guidelines here on CPT codes. Let's see, I thought down here, that's the reevaluation. So intervention plan or plan of care. It kind of broke down in different segments, and maybe this is something good for, like, I know Joanne couldn't be here tonight, but I know she had said, oh, I use that document all the time when we're teaching our students, where it's a kind of a good reminder of, you know, just the qualifications of things that we're putting in here. So interventions, you know, create, promote, establish, restore, education process, advocacy. I mean, so kind of some of those good buzzwords as far as remembering, I guess, the point of the documentation, or like the multiple avenues of documentation, of like how our note needs to talk about progress, but then talk about justification for services and talk about skilled analysis of you know, progress towards goals, things like that. So we can come back to that in more detail if people want to after, maybe. But let's see here. Whoops. Okay, you guys over here. All right, you guys can see this screen now. Back to the PowerPoint. Yeah, okay. Okay, so billing and reimbursement. So this, I went back to the textbook, just talking about, like, this is just more so defining, like most of us should know, but I feel like for people, or, you know, new students or new practitioners, just a reminder of different billing and reimbursement, like looking at our payer sources. And this is where I had specifically asked Lisa Hong to join in, because I know she runs her own business where that is helpful in the sense of, you know, like, I'm sure that means more to people that are actually seeing the reimbursement side of things. So please, by all means, Lisa, jump in if you have anything. But so obviously we know third-party payers, where that's basically they're agreeing to this assignment, and that's the predetermined amounts that the insurer is going to pay for each covered service, if the criteria is met. And then that allowable amount is considered payment in full. So they cannot bill or collect from the patient any amount other than unmet co-payments, deductibles, or co-insurances. Sorry, now I have to move this. So they put on here TRICARE. I haven't worked a ton with TRICARE, but maybe Megan has. Government funded program that provides healthcare benefits for active and retired military personnel. Does anyone have an experience with that? Like, is that generally a good insurance provider to work with, or is that a tricky one?
I have some experience. In general, there's like the pros cons. So I know one of the things being in that inpatient rehab setting right now, and I think it's very similar for outpatient, even though we've been advocating for this for, gosh, it feels like as long as I've been in practice, which is 10 years. TRICARE will not cover for OTA or PTA services. So
No, that's changed.
is
Like
it changed? Well, it still hasn't trickled down yet to where I've seen, unfortunately, Lisa.
Oh, really? Okay, so because for outpatient, I was understanding that it was allowed now, but
So maybe outpatient, because I know we still will have inpatients for, like at Elks Rehab, where it'll actually say on, like in the patient schedule, like on somebody's schedule, I know it'll actually say, TRICARE, no codas.
right. And my
So
system actually still says that too, because we use
just haven't changed it yet.
PTA to document.
Okay.
And I think that in my case, we still get that note, but it's the documentation system, not necessarily TRICARE, because it's up to your EMR to update that kind of stuff. So
Okay, well, that would explain that.
I'm not sure, but
no,
yeah.
that's good. That's good information. And I wish I was the one that could help make those changes. I certainly can bring it up and say, hey, why hasn't the system changed?
Right.
Yeah. And then, but good things that we've seen, for TRICARE and certainly VA, that would be the other one. And those are different things. Those are different pots. Those groups are the best in regards to getting things like durable medical equipment covered. So those are some nice positives for us as the OTs that, we're trying to be great hackers on, like, how do we help you find this tub bench on eBay? I've had people, like, how do we find this stuff that's cheaper, or lending closets or things. And the military funded tend to be the best at, you have to write a justification, but usually if you write the justification, they're very willing to help cover for DME, which is great.
Right.
While we're on sort of that topic of the assistants, do we know, because what was the other change? Was that Part B outpatient for not allowing, or like the reimbursement would be different for OTAs?
Yeah, so what happened is there's like a whole big chunk of money, right, that needs to go to medical reimbursement. And basically it's a they rob Peter to pay Paul kind of situation. And we got the short end of the stick on this one. So, and PTAs as well. So yeah, so in order to cover some other increase, they've decreased CODA payments and PTA payments. So we might be billing the same codes, doing the same treatment, and the CODA and the PTA are being valued less.
And that if I recall correctly from conference, AOTA is working very hard on reversing that, correct?
Very hard on that one.
Yeah.
Yes.
Which is fantastic. And APTA is also. Okay.
Yes.
Okay, so then so workers' compensation, obviously mandatory insurance paid by a business, that's covering employees who are injured on the jobs. Generally, yes, pretty straightforward to work with. Megan, do you have, or I guess anyone, do you have experience with workers' compensation?
I do. I've actually worked in a lot of practice settings in just 10 years. I really have. So I did used to work a ton in outpatient before I moved here, and definitely had a ton of workers' comp. The thing with workers' comp was, once those initial approved visits were coming to an end, it was on us, and this is where I was a huge advocate for my clients, of really documenting, as we're talking about tonight. And that's when I would love to talk tonight, because I have had fieldwork students, and talking about documentation is a big thing I work with them on. So I definitely have some pointers and things I'd like to bring up. But for workers' comp specifically, it was really making sure my documentation really demonstrated the progress, but also the need. And I fought tooth and nail, and I'm proud to say that I got some good victories for some of my workers' comp folks that really did need additional services beyond the initial visits that were covered. So documentation really came into play. And again, it was that balance of I had to show the need, and then I had to show also, hey, this person's making progress. You really should pay for them to continue because they have a high likelihood of actually getting back to work, which is the point.
Yeah. Yeah, that's perfect. And I do have a slide later, and like, I didn't want to put everything because there was a whole, I could figure out how to like take a picture and upload it when I upload this video from the recording for good resources, but there's like a whole page on just examples of skilled OT instruction, training, and education that might be provided, blah, 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 blah. And it's like all of these, I mean, we recommend to our students, and I think it's a required text now, but this is the textbook here. Because I mean, half the battle with our students, I feel like right now, or even just new practitioners or transitioning from one setting to another and just kind of learning the nuances that go with each practice area. This book just gives you, but I think particularly for our students where they're still just really piecing together, how do I say this? What is the best, phrasing that's showing the what's going on, like painting a picture in that clinic or in that intervention session, while also demonstrating the skill and not shortcutting your education and your skilled services, or the skill behind your services. So there's like a full page on just different phrasings that I think, and then amongst like the rest of the textbook that I didn't even get through, of resources that I could add into this. So we have that in a couple slides here. So we'll just get through here really quick. So billing and reimbursement. So obviously Medicare, we see a lot of that. We have Part A, Part B is what we're mostly seeing. We have the Part C, like the Medicare Advantage plans as well. I mean, this is where anyone in skilled nursing, because I know I was just actually talking to one of our graduates that works in skilled nursing, and it just seemed to me, and I'm disconnected from it a little bit now, but to me, it seemed like their administration had been going kind of back and forth on, especially with PDPM and grouping, and then how do you maximize reimbursement, which I know most of us as clinicians don't necessarily care, but maybe the business owner side of it, we do care. But I had just heard that it's like Part B's were kind of the money makers right now, and that you group your Part A's. Does anyone have any thoughts on that, or am I totally off?
I mean, so it's interesting because I used to work in long-term care like right away early in my career. So this was before the PDPM model change. And then now, like Elks, we do have our subacute unit, which is really supposed to function like other skilled nursing in the area. But we, as the therapists, I will say, don't really feel this on our side. I think we're pretty protected from it because they're just like, let's just get these people in, and then, whatever insurance coverage they have, and then that plays into their lengths of stay. I mean, I don't have to talk about this now, Brittany, but I would like to share what's happening about certain insurances and just things for people to be mindful of. But I do remember before the PDPM model and really struggling as that new therapist working in like a long-term care facility and being told in no uncertain terms, every quarter it would be, okay, we'll go check on that resident and let's see what new therapy plan of care we can drudge up. And, when it wasn't skilled and it wasn't appropriate and it wasn't meeting their functional goals, or they, and it really was all driven by when the rug levels were in place and having those ultra minutes and trying to meet those minutes. And it was just a bad time. I think it's a lot better now in some ways, because we still need to show our value. And that's where that PDPM model, and that's where I know AOTA's put out some really great articles on the value of OT with that model and reducing reimbursement for hospital. So we just have to strike that balance, because back in those days, it was a nightmare of just total fraudulence and trying to max out minutes and really unskilled people that were so inappropriate for those high ultra rug levels where you're like, what are we doing here? Like so-and-so cannot, this is not appropriate at all. And expectations for productivity were like 90-something%. sometimes 95, and you had to, you know, carry, I just, yeah. So anyway, I think it's better, actually. We just have to keep showing our value, and making sure that, because we don't have those unlimited minutes anymore, then, okay, well, as the therapist, you really should be putting together a very well put together treatment plan and making sure in the short time you have that you're actually addressing that client's goals, instead of thinking back in the day, we're like, oh, well, we have all these minutes, that'll just happen. So I would like to think it'll also actually make better therapists, and make sure their clinical reasoning and their actual use of their client's time is better as well.
I would agree with that. I mean, there were some real ethical dilemmas going on in skilled nursing at that point, and definitely hard. And so just a couple things to piggyback on what Megan's saying. I never managed in skilled nursing, and it's been a while since I've worked like in the trenches in skilled nursing, kind of like you, Megan, back before PDPM. But one thing there are times when things are not really hit at the therapist level, right? And so it's usually the manager that's kind of taking the hit and assigning those things and grouping those things and whatever. But I think that we as clinicians can be, what's really valuable is for us to understand that healthcare really is a business. So although we want to provide the best care that we can, the most ethical care that we can, most appropriate, it is still a business, and we need to do the best we can do to operate in that. Otherwise, the doors aren't open and we can't treat our clients. So just one thing to, you know, it's one thing to butt your head against the system and make changes where they need to be made, but you know, it's another thing to just be a poop and and go against your management. And then just one other thing on the Medicare Advantage plans. I understand that those can be very different and depending on the setting and depending on the plan. I mean, it used to be that Medicare Part A, it was kind of like an open slate. You guys do what you need to do, take care of our patient for 100 days, right? And then the Medicare Advantage plans, depending on what they were, would be like, you got to talk to us each week, and we've got to make sure they're making progress. We got to make sure that we're getting bang for our buck. And so there are some nuances, and hopefully you've got a team that can help you understand what is necessary there. So.
Yeah, thanks for sharing that, you guys. And I know, like, I was just looking at AOTA's website, or one of their resources for skilled nursing, and it was I'm sorry, I'm looking at my phone because I took a picture of it, but considerations for group, concurrent, and individual therapy. And I think that's always been a part of skilled nursing, but like with PDPM, it came out a combined 25% limit for group and concurrent therapy per discipline. Because I felt like that was a big thing that I was hearing as I was doing site visits and talking to different facilities, you know, as I was just trying to become, you know, re-educated or acquainted with this new PDPM without working in skilled nursing. It just seemed like groups were a really new thing, or I guess highlighted important, like let's maximize to get 25%. I don't know, Anna, like, I don't feel like you guys do groups at all.
No, I don't think I've ever seen a therapy group done at Quinn. We do a lot of co-treats. But no, I don't see much group therapy.
Because I know there's another facility in town that it seems like they are in the beginning conversations, it was almost like oh no, we need to do more groups. But I think that kind of was maybe a misinterpretation, and then re-swing it to like, let's figure out groups. But I know that, I mean, it makes sense, I guess, from that business model of if you can build groups, you can boost your productivity, and you can do that within the parameters that PDPM is saying or allowing. Just like dovetailing, when I first graduated, like dovetailing was still allowed, where you could see 4 patients at one time. And I believe that was all Med A's that you could do that with, and that got taken away because that was not so great. Any other additions on, I guess, groups?
I haven't gotten to see it yet. But I would be interested to see, I mean, I could see some positives, you know, reading through different things, like what are the recommendations for groups, and as OT practitioners, like we learned groups. So, I mean, we knew groups were done more. I know if Joanne was on, she could definitely excite us with like talking about how groups, I'm sure, were used more in inpatient psych. And certainly I got to see that and have seen groups in different settings. You know, some of the groups that have been put out there, and this is where, again, you know, we're kind of talking about, well, what are some of the issues, but, you know, we could also talk about ways that this could help OT practitioners leverage our skill and make us more valuable. You know, we could do groups for adaptive equipment retraining. We could do groups with caregivers. We can do groups. I would like to see more OT practitioners be involved in pre-op groups. And you could do it that way. And so it's a way that OT practitioners with our training could hopefully leverage groups. I mean, some examples of things that we've gotten to do at Elks. I got to take over our rec treatment a little bit recently, but I know back in the day, we were able to do group relaxation and integrative restoration, or iRest. So there's a lot of really great things that we could leverage for groups, and it could be a benefit to clients if it means that they actually are exposed to things more than just trying to get it one-on-one.
And I think, I mean, that's a huge point of like looking really at what does your population need, and can you service that, and maybe even have like an improved model delivery by utilizing a group versus looking at it from solely the business model of, oh, cool, I can put 4 patients together and get them all done, you know, and then boost my productivity, because that's probably not the point of the group.
No, there's a difference between group therapy and parallel play.
Yeah.
So,
Yep, exactly. And like, I mean, yeah, just when you're looking at it of, if you're taking turns throughout things, and that means that that patient's exposure in the group was like their turn that happened every, you know, 10th person or whatever, like maybe that shouldn't have been utilized in a group, or we could have designed the group in a different way to maximize participation better. Okay, so then back to, so we have Medicaid, so I think we're all familiar with that, how it's gonna vary state by state. Early intervention in schools, you know, whole new bag here with the Individuals with Disabilities Act. So we have that Part C for, I think, infant toddler, and then Part B for 3 to 21. But now we're at the real good stuff here. Okay, so skilled, reasonable, and necessary. You know, so skilled obviously means, you know, qualified professionals. You know, looking at what's the converse to that is non-skilled, so routine or maintenance. I think a lot of it, I mean, I remember when I was working at the Elks, you know, in outpatient care where it's like, has that patient plateaued, or is this actually medically necessary? Is this, obviously my interventions were hopefully still not maintenance, you know, because I'm still trying to progress and facilitate greater return after neurological injury, you know, but have they plateaued, and is this now medically necessary is something to think about for sure. But so as far as that, back to the skilled, so our documentation must demonstrate that they have potential for functional improvement. I mean, so that's where I struggled a lot with that population anyway, of like, I'm working on just maybe the slightest gains in hand function, but it's not actually equating to, you know, actually having improved functional use of the arm. And that was challenging, because it was just something that I had to promote or discuss with the physicians, discuss with the patients, with their families, as far as, is this still medically necessary? I see Julia has a hand up. Take the floor, Julia.
Yeah, so I have been struggling with this a little bit in the hospital setting. So I'm in acute hospital, and I do understand the difference between skilled and not skilled. However, I feel definitely since COVID, maybe even a little bit pre-COVID, that a lot of what the therapists end up doing, it's not that it's not skilled, I guess, but it feels like stuff that nurses should be doing, could be doing, and they just don't have the time to do it. For example, they don't have the time to offer getting a patient to the sink to do grooming hygiene stuff. And when I get the patient there, patient doesn't just fine. So all of a sudden I feel like, well, that's not necessarily a waste of my time or the patient's time, but it's not as skilled, it's not as beneficial as it could be, as it should be. Somebody help me with this.
Oh, I'm just nodding my head, Julia. I've worked in acute care too. I told you, I've done it all.
All of it.
All of it. So yes. And it's tough. It's really tough. And it's good. I've kind of swung the pendulum the other way, because when I was in true acute care, I did the things you tell students not to do. I did PRN for the first 2 years out of school. Would not recommend it, but I couldn't find full-time work. I didn't do an acute care clinical rotation in school. The only job available was acute care. It was like, okay, why not? Just make it hard. But I definitely had those same struggles because, and I think at the time, maybe I just didn't know any better as that early practitioner, where I was like, oh, here's my caseload for acute, and I just have to see these people, and it's enough to get them up to the sink. This is where I would like to see that communication and collaboration develop more between, especially OT practitioners and nursing staff members or the nursing assistants. Just so that way there's expectations of what is functional for OT to do and what is functional or not so functional, or maybe that they could do. Maybe what could make it functional, Julia, is what if you are working with someone and you say, oh, they're doing it just fine. But is there a way that the OT practitioner could help advocate for that client and make some recommendations to the nursing staff for the nursing staff then to carry over? Not for the OT practitioner to be doing that. And then just other thoughts are really challenging acute care therapists to think beyond some of those simple things. And this is where, again, my passion's pain management. So trying to incorporate some skilled pain self-management treatments in acute care. Trying to really get acute care therapists to think, okay, what is the best time? What is the best use of my one unit? And you're right. I mean, are there other things that you could be teaching or educating your client? Could you be facilitating some nice self-management skills for them? Is there something you could be doing with them that you're right? Thinking, okay, well, nursing could do this, this. What's actually skilled in this setting or with this client that really I should be the one doing and that nursing can't? But I think we should advocate for that collaboration and that communication, because could we bring the skill as that OT practitioner? Will we notice something during that session with the client that the nurse doesn't, and can we communicate to them to have a better outcome for that client, even if we're not the ones doing the self-cares with them?
I think another side of it, maybe like poking the challenging times that we're in right now. Because again, just talking to one of our graduates recently where I'm sure turnover in general maybe is a problem in a lot of places, but it sounds like nursing turnover in particular has been really challenging in these COVID and now post-COVID times. Where I know that at a staff meeting at a facility, it was all of this of therapy, help nursing, because nursing is drowning and they're pretty much trying to protect what little, strings those nurses are holding on to before like making a decision to leave or whatever, which is not great. Like that's promoting challenges for therapists of it's either fostering like low productivity, which is what it should be fostering. If we're going to be helping more with unbillable things, it should be unbilled, or it's promoting unethical billing of I'm seeing somebody for something that maybe is not as pertinent to their plan of care because I'm helping nursing, or I'm billing for maybe, grooming and hygiene following incontinence when that's more of a CNA type role, whatnot. I don't know if anyone else wants to speak towards that, but that could be part of, I think, some of the challenges of why our interventions maybe are seeming to almost be chosen for us based on the situations that we're running into a patient's room.
No, Brittany's 100% right, because Julia, we're experiencing that too in the inpatient rehab side. It was actually this time last year exactly that we had the surge hit, and we were asked as therapy staff to take on nursing shifts. I volunteered. I mean, I did like a 3 a.m. or a 4 a.m. shift one time. So that was happening. I think we had to hold our own because part of what was happening, like Brittany was saying, there was some unethical billing that way because we were asked as therapy staff, like, if you could answer call lights more or try to incorporate more cares into your therapy session, whether or not, like Brittany, you came up with a great example, like if somebody has bowel incontinence and they just can't, like, trying to make it as skilled as possible because you're like, how can I help you facilitate more independence with this task? Or at a bare minimum, can I facilitate your independence with directing your caregiver, which actually might be appropriate. But then there were other times where, you know, if we were just strictly helping out in that CNA role, then we were not billing for those services as an OT. We were just doing non-productive things, but we were helping. So I do think that's, you know, we have to help. I recognize that our nursing assistants are really strapped. But I do try very hard to be ethical. And if they're saying, oh, so-and-so really wanted a shower, we're not going to have time. I saw that you're seeing them for OT today. And I'm like, okay, yeah, we can do that because I know that I can make it functional. That's different versus, hey, here's this person, you know, so you have to take it case by case. But I think Brittany raises a great point because we're still seeing this with nursing turnover and lack of staff. And unfortunately, I don't think that's changing anytime soon. I think we need to make sure we know what is ethical and what should be billed and how can we make that time as skilled as possible.
I want to throw in there too that we don't think the same way nurses do. And so a lot of times when we're providing some of that treatment, could a nurse get the client up to the sink and do their ADLs? Probably, but a lot of nurses, their point of view, and this is just my own experience, but they're a lot of times doing for instead of doing with. And so I think that's that skilled piece that we bring in because we are promoting that independence and we're teaching them how to, and I'm not saying that's the case for all nurses, but I think I'm with you, Megan, that there is a way to make things skilled, even if you're asked to do a shower because they didn't have time. Surely you can work on balance or sequencing or a million other things. So it's the beauty of OT.
Well, and with that, the difference being that you could choose to, and this was always a point with my students, is like, could you choose to just walk that person to the sink and first of all, stand there, not say anything else, or stand there and chat about random things like the weather or football games the day before? Or could you be providing them education or talking about discharge planning if cognitively they can tolerate like divided attention, like talking to them while they're saying something? You know, can you make your conversation and education skilled in the context of that self-care? Because a nurse is not doing that. So that would be a difference as well.
And we are always we're such the great overlappers in OT, right? So we overlap in a lot of different professions. And it's our job to make sure that we show that unique piece that we bring to that table. So.
And making sure that we document that as well. So a lot of times when I'm documenting, I won't just say, you know, patient performed, you know, grooming at sink side. I might say patient performed grooming at sink side, OT also discussed or educated on. So, I mean, any of the education is absolutely billable. And to make sure that you're also documenting the education you provided, even if they were also simultaneously doing an ADL.
And I think, well, so one comment I wanted to add on to that before, that was a great segue to my next slide. But that comment was when I was talking to this graduate of our program, I was really impressed by her because she had said how she took the time and like, because it was kind of that, well, OT, can't you do the shower? And, you know, and she had done the shower a few days prior and it ended up, you know, because it was complicated transfer, get that patient into the shower. And then it turned out to be basically a dependent shower, which is still very billable, but we're probably not going to prioritize doing that every single day. We need to break that task down and figure out how to add some skill to it, add some greater independence and functioning to then make that more of an intervention that's appropriate. And so that nurse, you know, had said, they knew that they had done the shower. Well, can't you just do the shower? And so this graduate had talked to this nursing staff that's, you know, pretty new and just kind of explained, well, how that works as far as, well, we only get so much time with them, and I'm working towards these set of goals. And that CNA had no idea that, that they weren't just like on the floor picking up people as they wanted and doing kind of, floating around like a CNA would. And it was pretty insightful for me, because it's like, I was a CNA, so I remember those overlaps, but it just, we kind of take it for granted maybe that they even understand that how we're billing, how we're kind of having to follow these goals and make progress and show progress. And that's going to dictate if that patient can even stay at the facility and all of that. Like, they don't know that. And then I think the other part of it too is just really looking at and hopefully this is not a common problem, but I think it's been a topic out there on, nursing and therapy relationships in facilities. Where is it, the nurses are against the therapists? I think that is a relationship that's out there in some facilities that is only going to make everyone's job that much harder. So having that education, and then really maybe identifying issues, and then having management address those issues to really look at the culture as a whole, so that everyone is understanding what everyone else is trying to accomplish. And then how can we all work together for that? And my dogs are thirsty. Okay, so now we get to that justification. So here's that, what should our intervention, or what should our documentation be showing? So the book had talked about reflect intervention appropriate to the condition and their rehab potential. And then really obviously focusing on that skilled services provided versus, phrasing that maybe doesn't highlight what all is going into our intervention. So client was assisted or helped versus things like facilitated or remediated or other, those buzzwords. So that's why I put from the book, I put on page 45 and 46 are a whole bunch of examples, but I don't know if it would be helpful if we just kind of round tabled different phrases that we like to use, and I can compile a list, or what do you guys think? What would be the most beneficial? I am recording this so that hopefully more students can get on here and kind of start building their repertoire of their go-to phrases that are showing our skill while still, painting that picture of what the session actually entailed.
And we could just say phrases, Brittany, if that's okay.
Yeah, go for it.
Facilitated is 100% my absolute go-to. I don't know if there's a note I write that doesn't have that word in it at least one time. So, and it sounds so skilled. I mean, it's like facilitated, integration of energy conservation into blah, blah, or facilitated. I think other things, along that, showing the skilled is how, showing that you are working with that client towards self-management, because that's a huge piece. And then I'm trying to think, I actually have started to actually use the phrase teach back more in my notes. That got taught a lot to us. And that's a big, not just our discipline, but nursing, and trying to show that, you were providing skilled education in such a way that you're ensuring that the client is in a teach back way, they're able to demonstrate increased independence with what you taught them. So that's something I've started to use more.
Yeah, that's a big thing that I focus on. I use a lot of patient was educated on blah, 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 and return demonstration with this level of assistance, just to show that I provided some knowledge, I had the patient try it, and what their response was.
I use a lot of promoted, so use the word promote, like, so if we played a game together in pediatric setting, I don't just say we played ping pong, I'd say we played a game to promote this skill, or, so it's not just playing ping pong.
Mm-hmm.
Or in order to develop the skill.
Almost like we have to include a little piece of the activity analysis to really show why we're using what we're doing. Yeah,
no, I agree completely, because a lot of times it'll be one of my big pet peeves, and when I've had students, I've talked to them about this, you can't just say you're having somebody do arm exercises. You have to say what it's for. You have to say if it's to target the tricep muscles for improved push-up for, ADL transfer. And then I agree with that too. I'm trying to think of like working on standing and holding on at the rail because you're simulating grab bars and you're working towards them, releasing one hand to facilitate increased independence with clothing management for toileting hygiene. I mean, you've got to show you're not just having them stand there, because guess what? PT does that.
Mhm.
So we're not PT. We actually show like what are the functional things that we're doing it for. And I'm a big stickler with that when I have fieldwork students.
I think so. This is one that I really like too, but it's right here in the book where it's modifying and adapting activities. It's like talking about like, I graded up this challenge because of this improvement that I've seen. Or I modified the task secondary to fatigue as the patient got to the second half of the session or whatever. So I think those are maybe not necessarily using those words, which you could if it works out, but like documenting what's going on in your brain of I saw this, so I adapted it this way. That's our clinical reasoning.
I also like adding what type of cueing a patient needed. For example, verbal versus gestural versus tactile versus demonstration. Or I have a coworker who likes to say what or how much extra time a patient needs, like extra time, extended time, extensive time, which you could just use mod, min, mod, max extra time as well.
Trying to think if there's any other buzzwords that we talk about. But I think that's a pretty good.
I don't know if I overuse it a lot, but I'll throw the word functional in there a lot. And I'll throw in, I'll throw in occupational performance quite a bit too. So in order to address occupational performance deficits, because that's kind of unique to our profession.
The other thing I would say too, and I am not currently in academia, but one thing I have been trying really hard to do, and again, when I've had fieldwork students, is making sure you don't have to do it excessively, but we do have our practice framework. So I may say something like, for instance, like if I wanted to modify something that's so that people could, client could participate in an important religious practice. Well, payer may be like, well, why? And I'll be like, well, because religion and spirituality is an instrumental activity of daily living. Or just health management is the newest area of occupation. So why is it that an occupational therapy practitioner could justify helping their client, like maybe not, it's not even our HEP. I've done this with people before where they're like, oh, the physical therapist gave me these exercises, but I don't quite know how to do them and I want to integrate them into my daily life. We honestly could actually justify it from a health management occupation area perspective. Like with the OTPF, we actually can justify pretty much anything. So you could use that language, and I would hope that students are being taught that. I think I'm confident they are. I remember being in school 10 years ago and the latest OTPF, we were going through that. But that is something that I've tried to bring in just because I feel like there is a justification for addressing every aspect of that. And it is skilled if we're assisting our clients to find that way to engage in it as independently as possible. And that should set us apart from another staff member who just goes and gets a Bible for somebody.
And on a payer note, I don't know, I mean, I agree with everything you said there, Megan. But also we have to realize too that not everybody jumps on our OT bandwagon. So payers may be going like, well, I don't care if they go to church, you know, I mean, spirituality might be important, but it's not something I need to pay for. So maybe again, using that holistic view of a person, that spirituality is just as important as ADLs, but they may pay for ADLs quicker than they'll pay for spirituality. So just throwing that in there.
No, it's true. And I think that's where we need to just be mindful of reimbursement in different settings. So I would agree with that. I think that that could be a huge issue in reimbursement outpatient. I will tell you, especially from a billable standpoint, I feel pretty fortunate that anything I've ever gotten to charge or document or bill for appropriately in an inpatient setting so far, I don't think we've ever gotten pushback. So I think it just depends on, I think there is having that knowledge as that practitioner in outpatient settings. I think everything is so much more closely tied to this exact diagnosis, and these are the exact visits that are being covered, and you really need to be cautious with that. So any practitioner, I would caution them on that. But I do think that's where actually I'd love to see us leverage some, quite frankly, maybe some freedom in some of these other settings where it seems like we can actually do a lot and it is billable and we don't maybe get that scrutiny. So I can at least speak to that, having practiced on both sides of that. I think there's something to be said for leveraging that in a positive way.
I think that's also a place where our creativity can come into play. For example, taking the religious practices as an example. Well, we can work into that, but maybe part of that is making sure that the patient has their AM routine set up and they can do it in a timely fashion in order to get to their religious practice, et cetera, et cetera. So we can be creative in how we work at it.
And I think, so this is something that Joanne and I have actually talked about quite a bit, but maybe this is a small poll of the audience here, but the OTPF4, do you guys have a feel of like our practitioners out there, like the everyday practitioner that's at St. Luke's or at Portneuf or whatever that has been out of school for a while, are these clinicians aware that OTPF has even, changed to OTPF4?
I will admit I did not know until I had a OT student last summer and she did her in-service on it,
Awesome, good.
which was great. She showed us some of the changes, et cetera, et cetera. But it worked well because a lot of the OTs that I work with over there, we were utilizing version 3 with our students to help guide them in different ways, not on a daily basis, but definitely showing them that it's still a useful document that we incorporate regularly and we use it as a reference. And she was like, oh, there's a version 4 and it's like 4 times as long now. So we definitely utilize that and show our students that it can be beneficial to keep it on hand.
Yeah, and I think, there were some pretty big changes with them. And so that was just a thought of like, oh, that should probably be another journal club topic that we can hopefully promote that to just other clinicians out there that have been out of school for a while.
Or a future IOTA conference presentation.
Exactly, yes.
That would be great. It would be really great, especially because when we did that AOTA position paper statement on pain management, we heavily referenced the OTPF4 to really connect all of that. And then especially, like I said, I'm like obsessed with that health management occupational area. Like I'm obsessed with it. I'm like, yes, this is our in to like promote us and health and wellness and all, I think it's a way to really to create that path out of just the rehab space and more of that habilitation space and the prevention space. So I'm putting that in now, that we'll get someone to present on that. And on that note, I'm going to get off of this meeting and go on to the other one.
Thank you for your help, Megan.
Anytime.
And yes, and I think, just having the awareness of the OTPF4, I look at it as like, we're potentially like, if us practitioners out there in the field are not as in tune to those changes, we're potentially missing out on, just being able to advocate for our, you know, just all of what our profession can encompass. And I think that's, you know, we've seen that over the time of just the struggles of maybe our discipline getting more narrow because other disciplines are coming in and doing that, when why weren't we kind of utilizing our discipline to the fullest extent that it was intended to? Okay, so let's see a couple more slides here. So therapy students, I thought this one, I mean, always just good to plug that out there, particularly Med B, where, you know, not that this is new, but it is something that is, it specifically says that, I mean, student participation is allowed. However, it even specified in the book here where it's like not just line of sight, like it goes on to quantify that it's allowable if the qualified practitioner is present in the room, directly involved in the care and responsible for the services. So they shouldn't be performing other tasks or treating other clients. So that's very different than Part A. And that could be certainly lead to billing issues. Use of aids. So we all probably know this too, as far as they cannot provide skilled therapy. There can be a lot of things that they can do. But this is kind of where that non-billable services of it's a routine task where it's not new. They've already learned it. So therefore it's not skilled. So it's a client outcome is in the environment or stable environment that's predictable. Professional judgment is not needed. The task has already been established and performed by the client. Those are things that the aides can do. OT practitioners are the ones supervising and properly training the aides. They are unskilled tasks and not billable. And then my last two slides from just gathering data or information, just examples of fraud and then examples of abuse from Medicare. So, I mean, just to be mindful of, I mean, I think most of us probably should be mindful of, because it's, you know, like, oh, I billed for a session that didn't happen. Yeah, obviously that's going to be fraud. But misrepresenting or describing a service as covered when it's not, I mean, I think a lot of this is more for on the billing end of things. Let's see what our other one says. Excessive charges. I mean, here's that gray area of providing or billing services that are not medically necessary. That means, so again, doing your own thought process through of double checking yourself, like, is this actually still medically necessary, or it has this transition to more maintenance? Or should I, you know, could I show my maybe decreasing my frequency to every month because I'm checking in and that's making it medically necessary versus, you know, continuing on every week or, you know, twice a week or whatever. Providing services that do not meet recognized standards of professional care. So, I mean, that's pretty broad, but I would think that this is maybe where, maybe not quite to the extent of like not utilizing evidence-based practice, but I think we're kind of seeing more of that as far as justification with evidence-based practice. So, I mean, that could be something in there that, are we really doing the best services for our patients, which is promotion to continue to come to these journal clubs and be involved in evidence-based practice. Billing Medicare using a higher fee schedule than the one used for non-Medicare. So that's more of the administration or, you know, the people that are doing the billing. Yeah. So then we've already pretty much built these in, but this was kind of that, and that's perfect how that happened, of just kind of the conversations that I had wanted to have amongst us clinicians. So I don't know if there's anything else, any other burning topics that anyone else wanted to bring up, or I'm super appreciative of the collaboration and the great discussion that you guys brought.
I'll just throw in a couple things we talked about, like codes not getting reimbursed and documentation.
Yeah, oh, yes, please.
It is sometimes like, I remember going to a conference and being like, wow, we have a sensory integration code. We should totally build that. And then finding out it doesn't get reimbursed very well. And so asking what some of the some of the codes are that get reimbursed. I mean, I would say in my clinic, probably 90% of what we bill is therapeutic activity. And I would love to differentiate some of that stuff that we do, some feeding, some things like that. But there are codes that don't get paid or don't get paid without more documentation, like feeding codes don't get paid unless you are documenting things like BMI and favorite foods. And I mean, it takes a little bit of extra. And I was all excited about a cognition code too. And turns out that one just covers TBI right now. And so, you know, so it can be a little bit limiting. So just talking with your clinic manager, your billing people about what gets reimbursed and what doesn't can be helpful for you so that you do get paid for what you do ethically.
And this was a while back, but I remember at St. Luke's, I had an outpatient. I think the patient had a traumatic brain injury. And so they made it from inpatient, got home to out, you know, and then started coming for outpatient services, but they certainly still were not independent in their home. And so I was continuing to work on ADLs to facilitate greater independence because the patient's wife had to start going back to work. And so the goal was to get that patient to be able to be home by himself for a short amount of times and then building that up. And so I remember working on toileting. And so I billed the ADL code and it was a Blue Cross patient and the Blue Cross code got denied because ADLs were only for inpatient. I have no idea if that's still something going on, but it was insightful to me. Like, oh, I'm not allowed to bill ADLs as an outpatient therapist because they're done with that phase, which is so not true, but yeah, just a little snafu.
Yeah. And then, and I think that we do get reimbursed for ADL now, but
Okay, good. That's great.
But like the work comp and sometimes others will ask you at the beginning when they're doing a pre-authorization about what codes you will be using. So sometimes you need to say ahead of time, these are codes that we'll be using. And like state insurance fund may only pay that code. So if you do something different, or maybe you end up using a modality that you didn't plan on using or something, you may not get paid for that because it wasn't an authorized code. So keep those things in mind too.
Anyone else have anything they would like to share?
This is a little off topic, but I know that when I stopped doing home health, the biggest struggle with the PDGM change was that we had to show significant progress, not just progress, but significant progress. And I don't know if that's across all settings or what, but we felt that was pretty limiting, which led to the situation of them going to outpatient before they really were stable at home. But I don't know if that is a struggle that continues or if they've kind of adjusted for that.
We're not getting too much flack about that in outpatient that I know of, as long as there is progress. More so when we're doing, like when we're hitting, I know therapy caps aren't the same as they used to be, but when we're hitting those thresholds, they are looking for more, like, why should we continue to give you money for this? So I don't see all of the bills either though, so.
Yeah, and that, I mean, maybe at some point I can get like someone that this is what they live and breathe, and we can get into all of the nuances, but
Trina Reinhardt is really well versed in this.
I tried to get her to come and she had it was a hard time for her to be here.
Yeah.
But she did give me a contact, but that person was out of the office until.
Oh. Yeah, she's really good with that.
Yeah. Well, perfect. So I appreciate all of you guys coming. So our next date, let me just look, it's the first Monday of November, which looks like is November 7th. So hopefully I'll get that out a little bit earlier this time. But thank you guys so much for coming. This was great conversation and I really appreciate all the collaborative input and the support of our journal club.
Thanks for doing it.
Yeah,
Thanks, Brittany.
figure out how to stop my recording. Oh, up here.